Screen sharing.
Good morning, everyone. Good morning, Naran sir. Good morning, Vijay sir. Good morning, all the professors. Shall we start now, sir?
Okay, now just good morning to all of you.
Good morning.
We'll start the session. Good morning. We'll start the session, and
Yes.
welcome to all of you. And Professor Vijayan of Royal Care Hospital will be the chairperson today, and Professor Shivakumar and Thirur children will present. Will be the moderators and present cases. It will be Professor Shivakumar. They will present cases from Mohan Kumar Mangalam Medical College Hospital Neurology Department. I hand over to Vijayan to conduct the proceedings. Henceforth, Vijayan, you can take over and conduct the proceedings as you please.
Thank you, sir.
Vijayan, you can take over.
Yes, sir. Thank you, sir. Thank you for the opportunity.
Thank you. Thank you.
And thank you, Shivakumar sir. Thank you, Thiru sir, for presenting these cases. Without much ado, we'll start off with the first presenter, sir. Please, Dr. Abhirami.
Yes, sir. Good morning, sir. Here I am presenting the case on interesting case of acquired paralysis with overlapping etiologies. My patient, Mrs. ABC, female, 54 years, who is housewife, not steady from Tirupur, came with chief complaints of weakness of all four limbs for 1 year, unsteadiness while walking for 5 months, paresthesia and burning sensation of both hands and feet for the past 5 months. History of presenting illness. Patient was apparently asymptomatic 1 year back. Then she developed history of difficulty in using all four limbs, which was insidious onset and gradually progressive to the present state. Initially in the form of difficulty in raising arm over the head while wearing blouses and difficulty in reaching for objects that are kept at height. But there is no difficulty in mixing the foot and in gripping the objects with both hands. Along with upper limb weakness, she also had history of difficulty in sitting down and getting up from the squatting, and there is difficulty in climbing up and down the stairs, which is not associated with buckling. No history of difficulty in gripping the chapels, and no history of tripping off toes. Weakness gets worsened with activity, due to which there is limitation of her daily activities. Previously, she used to cook food and do household activities. Due to this fatigability, now she stopped cooking and other household works. Patient also feel improvement of weakness in the morning and the same worsens as the day passes. The limbs are neither flaccid nor spastic. There is no associated muscle wasting, thinning, cramps, or muscle stretching or any other involuntary movements. Within a month, she also noticed a drooping of both eyelids, same on both eyes, which worsens on watching television and also shows diurnal variation associated with occasional diplopia in both eyes for all directions, which improves after some rest. History of difficulty in chewing for hard foods like chapati and meat. So the patient is now preferring soft diet. After 2 months, she noticed history of difficulty in lifting off the head from the pillows and difficulty in turning side to side and getting up from the bed. With the above weakness, patient was ambulant till 5 months back with no sensory or bowel bladder symptoms. Then, 5 months back, patient developed paresthesias of both hands and foot in the form of tingling and burning sensation. History of numbness of foot and inability to pursue the ground sensation, and she felt as she was walking over the cotton wool. Gradually, she developed unsteadiness while walking with the swaying to either sides, which was insidious in onset, progressive, and it was more in the dark and on closing eyes, which further worsened her lower limb existed weakness. And the patient started walking with support. Then, due to the fear of increasing falls, she started crawling, and now she is having difficulty for even standing with support. But the upper limb truncal muscle weakness remains the same. She also had tingling and pricking sensation along with pain all over the body, more in hands and in foot. Able to perceive hot and cold water sensation while walking. No history of root pain or girdle-like sensation in the trunk. No history of loss of consciousness or altered sensorium. No history of speech disturbances. No history of memory or sleep disturbance. No history of delusion, hallucination, and no history of seizures. No history of alteration in perception of smell, no history of blurring of vision, able to differentiate colors, and no history suggestive of light blindness. Able to perceive hot and cold water sensation in face while washing it. No history of deviation of angle of mouth, drooling of saliva, difficulty in closing eyes, or wrinkling forehead. No history of hard of hearing, tinnitus, or vertigo. No history of difficulty in speech, no nasal twang to speech, no regurgitation of food or swallowing difficulty. Able to roll over the foot and pushes the foot backwards. No history of spilling of food while taking to mouth, no clumsiness of hands. Able to feel bladder fullness, initiate micturition, feel the passage of urine, able to hold midstream urine, able to completely evacuate the bladder without any dribbling. No history of involuntary defecation. History of constipation is there. No history of giddiness on getting up in the morning. No history of sweating disturbances or palpitation. But she is having history of foreign body sensation in eyes and decreased tear production. Patient taking more water to clear the food particles from the mouth, and she feels excessive dryness of mouth. History of recurrent oral ulcers is there. No history of rashes, joint pain, fever, pedal edema. No history of cough with expectoration or bleeding manifestation. No history of fall from height, trauma, or lifting heavy weights. No history of headache or vomiting. No history of bed sores, recurrent non-healing ulcers, and dark color urine. Past history, known case of hypothyroidism for the past 2 years. History of blood transfusion done for anemia 9 months back. Not a known patient of diabetes, hypertension, bronchial asthma, tuberculosis, or malignancy. Patient takes both vegetarian and non-vegetarian diet. Not a known smoker, alcoholic, or tobacco chewing. Housewife, no history of exposure, suggestive of any toxin exposure. Family history, no history of similar illness in the family members. Menstrual and obstetric history, attained menopause, has 2 sons through normal vaginal delivery. Treatment history, taking tablet thyroxine 75 microgram for the past 1 year. And in summary, 54 years old female admitted with chronic progressive neurological illness in the form of fluctuating proximal muscle weakness of both upper limbs and lower limbs, along with truncal muscle weakness. She also had fatigable ptosis and occasional diplopia, along with chewing difficulty for the past 1 year, and having pain, paresthesias of foot and hand, with progressive sensory ataxia for the past 5 months duration, with constipation and no other bowel, bladder, or higher mental, other cranial nerves, cerebellar involvement. She also had dry eyes, dry mouth, and recurrent oral ulcers with hypothyroidism.
Abhirami,
Yes, sir.
why did you mention about gallbladder pathology? You mentioned no gallbladder symptoms. Why did you make a specific mention?
Gallbladder. No, sir. Bowel bladder symptoms, sir. Not gallbladder, sir. Bowel bladder pathology.
Oh, sorry. Okay.
Yes.
The other thing is, how low was the hemoglobin and why did she need transfusions?
Yes, sir. At 9 months back, she developed some volume, presented with the volume overload state at private hospital, sir. That she was found to have hemoglobin of around 6 gram per deciliter. So she was transfused, sir, but she was not evaluated for that anemia, sir.
And she, 2 transfusions at the same time?
No, sir, only 1 transfusion. For 6 gram per deciliter, she was transfused once, sir. That's it, sir.
Oh, I thought you mentioned 2 transfusions. Okay.
Yes, sir.
Wonderful history, madam. Very nice history. Only that instead of mentioning female and male, please mention lady and gentleman.
Okay, yes.
Where would you localize, madam?
Sir, in this patient, the motor complaints started 1 year back, sir, which is more of a proximal involvement, sir, with fluctuating type of weakness, sir. More in the patient feels uncomfortable in the morning, and thereby the day passes, she feels fatigability, sir. And within that, she developed both upper limb and lower limb weakness. Along that, she was not sure when the diplopia started. Within a month also, she was having diplopia, sir, for watching television. So more of with this chewing difficulty. First, my pure motor weakness, initially it is 1 year duration. Then after 5 months only, she developed sensory symptoms, sir.
1 minute, Abhirami. One,
Yes, sir.
hold on for a minute. Yeah.
Yes, sir.
At that point of time, with that history,
Yes, sir.
what would be your localization? What is the likely thinking which is going on in your mind?
Yes, sir.
At that part.
Yes, sir. With the pure motor, sir, I would like first, because of this fluctuating weakness, like to localize to neuromuscular junction, sir.
Yes.
Yes, sir.
Almost all features are there. Straight
sir.
away, you can say it is a neuromuscular junction involvement, probably myasthenia or myasthenia related. Yes.
Yes.
Okay. Then
Then, sir,
5 months later, symptoms 5 months later.
5 months later, she developed the sensory symptoms of mainly involving large fibers, sir. Even though she was having this pain and paresthesia, she was able to perceive this hot and cold temperature, but she was not able to perceive the ground sensation, sir. So she started developed a ataxic gait. Initially, the ataxia was also insidious in onset. She feels more ataxic in the dark, sir. So mainly involves the large fiber peripheral nerves, which worsen, or peripheral nerves large fiber involvement.
You also said tingling pain.
Tingling pain, sir. Also, large fiber predominant, sir, but tingling and pain is also there, sir.
So the unsteadiness, you would consider it as a sensory ataxia.
Sensory attacks, yes, sir.
Okay.
Which is worsening and worsened her her upper limb weakness remains the same, sir. Same kind of fatigability for the past 1 year, no worsening of that, but lower due to this, she is now almost dependent, sir. She having even difficulty in standing, sir, with support. So dependent for her activities, sir.
So neuromuscular junction and peripheral nerves.
No, peripheral nerves, yes, sir.
Do you want to
continue the next group of symptoms?
Yes, sir. Next to symptoms, she also having this feeling of dry eyes and dry mouth. For this, but the duration of this illness, she was not for a long time, for around 2 years she was having, but this dry eyes is troubling her for the past 1 year, sir. Along with this weakness, and she noticed that also, sir. This weakness made her to recognize the dry eyes symptoms also, sir. Which is suggestive of autoimmune pathology. I would like to.
Which came first, ma'am?
Sir, this eyes, dry eyes for
Which
long
came first?
duration. Long duration, sir. This dry eyes and dry mouth for about 1.5 years, sir. Then comes this motor weakness. Then this sensory symptoms, sir.
What about oral ulcers?
Oral ulcers, yes, sir. That is also for the past 1 year, on and off, she is getting this oral ulcers, sir. Bad breath also she is getting.
So what do you think of that?
Maybe of Sjogren, sir. This dry eyes and the dry mouth, maybe connective tissue disorder, Sjogren syndrome, maybe.
Okay.
Sir?
Anyway, the Vijayan is there, the expert.
No. Sir, anyway, madam, when you say systemic symptoms associated with peripheral nerve and probably neuromuscular junction also, and then you commit on etiology. And of course, she also has hypothyroidism that also could be autoimmune.
Yes, sir.
So when you combine and say, whenever you say in the exam, you combine and say systemic symptoms are associated with a possible peripheral nerve and a possible neuromuscular junction pathology. So I would like to come that.
Yes, sir.
Anything else, madam, apart from Sjogren?
Non-neurological manifestation of Sjogren?
Yes. Yes, sir. Hello, sir.
Anything else would you want to think of?
Does she have any non-neurological manifestation of Sjogren?
Non-neurological, apart from dry eyes, dry mouth, and oral ulcer, she's not having any other symptoms of Sjogren's. Like,
Okay, okay.
Any other thing apart Sjogren would you like?
for paraneoplastic also we have to think, sir, with the autonomic symptoms like dry eyes and dry mouth, with the paraneoplastic etiology.
So non-infective inflammatory, and also you would consider paraneoplastic.
Paraneoplastic, yes, sir.
Yes, ma'am. Any chronic infection that can cause this?
Chronic infections like atypical presentation, viral markers we have to see to rule out HIV status, sir.
Yes, madam. Good.
Yes.
Sorry, what did you say? Viral?
Viral, yes.
HIV.
Abhinami, what did you say? Any?
HIV,
Sorry?
HIV.
HIV status.
Oh, okay, okay.
Dr. Abhinami, which one is dominating? Either myasthenic symptoms or neuropathic symptoms?
So now my neuropathic symptoms worsen and worsen her functional states. With the myopathy, she was ambulant for the past 8 months duration, but due to this neuropathy, she is disabled.
Madam, would you like to consider toxic also, long-term
Yes,
toxic intoxication?
Toxic neuropathy. Even though there is no exposure, we have to consider that also. So toxic neuropathy causing sensory symptoms.
Abhinami, what toxin? Can you be more specific?
Yes, cisplatin may cause this type of sensory ataxia with pyridoxine excess and vitamin B12 excess in causes this kind of symptoms and chemotherapeutic agents like cisplatin.
Allegation, sir. Anything else, sir? Allegation, sir?
I think, sir, I'm also thinking common CDP plus myasthenic, most probably autoimmune or collagenous disorders.
Madam, your Gen Z, would you also think about something else? Because multiple areas are involved now: neuromuscular junction, nerve, dryness in the eyes, hypothyroidism.
Yes.
What?
Any drug, but this is not.
Abhinami, your voice
And
is
maybe you
breaking.
can include when you don't know.
Your voice is breaking.
Yes. When you don't know, you can always include mitochondrial also as a difference.
Mitochondria, yes, sir.
And genetic disorders, and nowadays they play.
Yes, sir. Genetic disorders, yes, sir.
Something new is being discovered every month. So when the
Yes.
exam, you can tell all these differential diagnoses.
Okay, yes, sir.
No, what did you say to Vijay's question of in gens? If it were a gent, what would you think of?
Yes, sir. Gen Z, sir. Generation Z.
Oh, sorry. I thought, see, you, okay, male, female, but I wanted to say gent and ladies, so I thought for a male sex, you wanted to say gents.
Yes.
Right.
Male and female are dehumanizing words. Adanale. So.
Madam, proceed.
Yes, sir. Then general examination. Patient was conscious, oriented, comfortable, cooperative for the examination, well built and nourished, afebrile, not dyspneic. At present, she was not paler, not icteric, no cyanosis, no clubbing, no pedal edema, no significant lymphadenopathy. Oral ulcers present and thyroid swelling is also there. No scars, burns, ulcers in the extremity, drop peak ulcers or contractions, and no nerve thickening and no neurocutaneous markers. Pulse 100 per minute, regular in rhythm, normal volume and character, felt equally in all peripheral pulses, no radioradial or radiofemoral delay. Blood pressure measured in right upper limb in supine posture, it was 100 bar 70 millimeter of mercury, and in sitting 110 bar 70 millimeter of mercury. As patient can't able to stand, Standing blood pressure was not measured. Respiratory rate was 14 per minute, regular thoraco-abdominal type of breathing, and temperature was normal. Neurological examination, higher mental function, conscious, oriented to time, place, and person. Speech and language normal. Memory, immediate, recent, and remote memory intact. No emotional liability, and MMSE was 26/30. Cranial nerve examination, olfactory sense of smell equally and normally perceived on both sides. Optic nerve, visual acuity 6/6 on both eyes. Field of vision, color vision, and fundus normal. Oculomotor nerves, extraocular movements bilaterally, full range of movements, but practicable on repeated testing. Pupil 3 mm on both sides. Direct and indirect and accommodation reflex normally present. Toes is bilateral. Fatigable toes is present. No nystagmus and no features of Horner syndrome was there. This is patient video. Fatigable toe, demonstrating fatigable toes. Is on trigeminal nerve, sensory, diminished in all divisions, motor, jaw opening and lateral deviation on either sides weak, corneal reflex, conjunctival reflex present, jaw jerk not elicitable, and facial, orbicularis oculi weak, and other muscles of facial nerve, other muscles applied by the facial nerve was normal, sensory normal, reflex and corneal conjunctival intact. Vestibulocochlear nerve, Rinus positive, air conduction is better than bone conduction, and Weber's not lateralized, no nystagmus. Uvula palatal arches and movements, uvula centrally placed and symmetrical, bilateral symmetrical arches moves equally. Gag reflex present and palatal reflex is also normally present. And trapezius and sternocleidomastoid power was weak. It was 3/5 on either side. And hypoglossal nerve, inspection, no waste tongue. It was not wasted, no fibrillation. Tone power normal, on protrusion lies midline. Motor system, upper bulk, no wasting, fasciculation, fibrillation, contractions, and deformity. Measurements, there is no obvious asymmetrical. Muscle bulk preserved on both sides. And tone normal. Power, neck muscle flexion and extension 3/5. Extension 4 minus 5 on either sides. Shoulder, shoulder joint, all movements restricted to 3/5, and elbow 4/5. Distal plantar, dorsiflexion, plantar flexion. Sorry, wrist palm of wrist movement extension and flexion, palmar flexion and the dorsiflexion 4+5/5. Hip, all movements 3/5, and knee flexion extension 4/5, and ankle, dorsi plantar flexion, inversion, eversion, all 4+5/5. And toe grip also good. Superficial reflex present, and plantar showed flexor response. Deep tendon reflex, jaw jerk not elicitable. Biceps hyporeflexia on either sides, and all other reflexes were absent. And primitive reflexes was also absent. Gait can't assist, severely ataxic, and no involuntary movements. Sensory system, spinothalamic tracts by pain and temperature, bilaterally diminished in upper limbs from fingers till mid-arm with no definite level, and lower limbs from toes till mid-thigh in trunk relatively preserved. Posterior column vibration diminished in lower limbs up to anterior superior iliac spine. In upper limb, she was able to feel till elbow joint, and she was not able to feel till elbow joint, and position sense impaired on both the lower limbs and upper limbs. Romberg sign can't able to elicit. And cerebellar function test, no titubation, no nystagmus, no dysarthria, no rebound phenomena, no intentional tremor, no pendular knee jerk, and tandem walking can't assist. Coordination test, upper limb, finger nose test, able to do with eyes open, impaired on closing eyes. Finger nose test, bilaterally normal, able to put dot in the center of circle. Lower limbs can't assist, no dysdiadochokinesia. No resting tachycardia, no abnormal sweating, no signs of meningeal irritation. Spine and cranium normal. Cardiovascular system, S1 and S2 heart sounds normally heard, no murmur. Respiratory sound, vesicular breath sounds heard. Abdomen soft, no organomegaly, no prefluid. Summary. Neurological deficit in the form of fatigable ptosis with weakness of muscles of mastication, symmetrical proximal predominant areflexic weakness of both upper limbs and lower limbs with the truncal muscle weakness with the flexor plantar response and impairment of all modalities of sensations, predominantly large fiber involvement. Without bowel bladder and other cranial nerves and cerebellar involvement. Yes.
Good summarization,
One
Abhinami.
thing, madam.
Yes.
Excellent, madam. Did you mention autonomic symptoms, madam?
Yes, autonomic
Examination.
function. Yes, no resting tachycardia, no abnormal sweating. And for other autonomic function tests, she was not cooperative for this Valsalva and for deep inspiration, she was not cooperative.
Sweating is another thing which you have to mention. And also,
Yes.
did you mention peripheral nerve thickening, madam?
Yes, she mentioned.
In general examination, I mentioned, sir, no peripheral nerve.
Okay.
Yes, sir.
Hello.
Excellent.
Yes, sir.
Is there any augmented, what about the augmented reflexes on tapping, repeated tapping of the ankle jerk? What was the ankle jerk?
Not elicitable, sir. Areflexia was there. Even on repeated tapping also areflexia.
Why it is important?
Sir, in limbs, if we suspect with the reflex will be on repeated tapping, reflex will be elicitable, sir, in case of limbs.
Good.
Good, good, Abhinami. Abhinami, that was Professor Justin who asked you the question.
Yes, sir.
To be your examiner.
Yes.
Yes, sir.
Yes, madam. Proceed.
Yes.
Please proceed.
Yes.
Please proceed with localization.
Yes, sir. Then again, I'm localizing with the summary into neuromuscular junction, sir. And for the sensory symptoms, either peripheral nerves or DRG, dorsal root ganglia, I would like to conclude. I would like to localize, sir.
Okay, madam.
Yes.
Please proceed, madam.
Yes. And the probable etiologies could be on the background of autoimmune disorders. Either it is associated with autoimmune disorder with associated neuromuscular junction, more of like myasthenia gravis, and with the sensory. If we can also suspect limbs also in this patient, since age is in that elderly patient with the sensory and neuromuscular limbs, we can also suspect, sir.
One thing, the prominent striking feature is absent reflexes, isn't it, madam?
Absent,
In
yes,
myasthenia gravis, how would the reflexes be in myasthenia gravis? Routine myasthenia gravis.
Reflex will be intact, sir. In severe weakness only, reflex will be absent, sir. But more of the cases, reflex will be retained, sir.
So if reflexes are absent in a case of myasthenia gravis, then what is the diagnosis?
Associated with some peripheral neuropathy or severe myasthenia, sir. Or otherwise, is
Yeah.
yes.
Vijayan, any
Sir.
possibility of Poem syndrome? Because he has got neuropathy.
Yes, sir. But endocrine abnormality is there, sir.
Hyperthyroid, skin changes also there. So only
Yes, so there
problem
is
is organomegaly is
endocrine
not there.
abnormality, but she doesn't have any organomegaly and skin symptoms are not there. One thing, madam, if reflexes are absent in a case of myasthenia gravis, you always suspect paraneoplasty. That's all.
Yes, yes, sir.
That's all.
Yes.
Yes, madam, proceed.
Yes. Sir, proceed with investigation, sir.
Yes, madam, please.
Yes, sir. Investigations: random blood sugar 100 milligram per deciliter, HbA1c also 5.6%, urea 15 milligram per deciliter, creatinine 0.6 milligram per deciliter, total bilirubin 0.9 milligram per deciliter, sodium, potassium, and serum CPK also normal 135, and the whole blood count 8,600 cells, and hemoglobin 11.2 gram per deciliter, and platelets 4 lakhs. Peripheral smear was showed normal steady, and viral markers was negative. TSH was around 3.14 international units, and the CSF weighted protein 38 milligram per deciliter, sugar 76 milligram per deciliter, cell count only 2 cells were found, and cytology was A cell-less smear. And we also did neostigmin test, sir. This is before neostigmin test.
கையில பிடிக்கமா பிடி பிடி கை முட்டி மடக்கு முட்டி மடக்கு முட்டி ஃபுல்லாக மடக்கம்மா மடக்கு 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 வெளியே தள்ளுங்க 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 இந்த சைடு தள்ளுங்க இந்த கை முட்டி மடக்கு முட்டி மடக்கு வெளியே தள்ளுங்க சரி படுக்க இந்த கால் மட்டும் மேலே முட்டி மட்டும் மேலே தூக்கி இந்த வலி இருக்காமா இந்த கால் மேலே தூக்குங்க கால் மேலே சரி இந்த கால் தூக்குங்க
ரெண்டு கை மேல தூக்கி வைங்க. தூக்குங்க தூக்குங்க. ரெண்டு கை தூக்கி எவ்வளவு நேரம் வச்சிருக்க முடியுதோ வைங்க. தூக்குங்க நல்லா. சரி கை கால் தூக்குங்கம்மா. கை கீழே இறக்கிக்கோங்க. காலை தூக்குங்க. தூக்கி ஒரு காலை தூக்கி அப்படியே மேலே வைங்க. படுத்துக்கோங்க. படுத்துக்கிட்டே தூக்குங்க. இல்லை உட்காந்து தூக்குறீங்களா? சரி உட்காந்து தூக்குங்க. படுத்துக்கோங்கம்மா, அதான் ஈஸியா இருக்குமா. தூக்குங்க தூக்குங்க. நல்லா தூக்குங்க. நல்லா தூக்குங்க. அப்படியே வச்சிருங்க. தூக்குங்க. இந்த கால் தூக்குங்க. தூக்குங்க. தூக்கலாம் தூக்குங்க.
Nerve conduction study was done. Motor conduction study was normal. Then sensory nerve conduction, sural north stimulatable and bilateral median nerve sensory amplitude was decreased, but the ulnar was normal. Ulnar showed normal amplitude, and the RNS we did, which showed a decremental response. And special investigations we also proceeded. Anti-TPO was elevated. It was around 40.2 international unit, and ANA we did was positive, 1:1200 ratio, which showed a speckled pattern. And acetylcholine receptor antibodies we did, it was below 0.1, and VGCC antibody we also sent, and it was also less than 1. And ANA profile patient was not affordable, and we are planning to send on further visit of her. And ultrasound abdomen we did normal. Ultrasound math done. Multinodular goiter, Tirax stage 2. And echo normal. CT chest also done, which it was normal steady. MRI brain and spine was unremarkable. Yes. Sir?
Yes, madam, go ahead.
Yes, sir. So the diagnosis is autoimmune disease, probable Sjogren syndrome with autoimmune thyroiditis with myasthenia gravis and sensory neuronopathy. I would like to conclude for this patient.
Madam, I think you should still keep paraneoplastic as one of the
Yes.
yes. All this can occur with paraneoplastic, especially the classical teaching is myasthenia gravis. If reflexes are absent, you should always think of paraneoplastic.
Yes.
That also should add to the differential diagnosis.
Yes, sir.
In this case.
Vijayan.
Sir, sir.
No. Reflex is being absent. Could it be secondary to the sensory neuropathy?
Yes, sir, definitely. But the teaching in a clinical case,
normally,
if you
yes.
have myasthenia with
yes.
that.
Correct. Normally,
Yes, sir.
in
Yes, sir.
neuromuscular junction, if the reflexes are down or absent, one should consider LEMS. But in this patient, I'm asking because he also already has a sensory neuropathy, that should be accountable for the A reflexia.
Yes, sir. The sensory neuronopathy can be a manifestation of a paraneoplastic again.
Yeah, that's. Abhirami, what do you think of myasthenia without any receptor antibody being positive? Did you test for MuSK also?
No, sir, MuSK was not done, sir. Only acetylcholine receptor antibody we did, sir. And we suspected LEMS also. We did voltage.
No, VGKC paathirukken. Yeah.
Yes.
VGKC included VGCC also.
Yes.
which can't be done here. Was it done?
Yes, sir. Report was outside lab we sent, sir.
Oh,
It was
very
sent
good,
to-
very good.
Yes, sir.
Oh, excellent, excellent. Right.
Yes, sir. Good. For report, we took around 1 month, sir. Then only we got report, sir. It was
So,
sent to
what
the-
is your thinking on that neuromuscular junction problem?
neuromuscular junction? Yes, sir. It could be paraneoplastic. Because of that, it could be with the negative. Must be didn't do, sir, because of this. Either appendicular involvement, we didn't. It must.
This is an open question. I do not know. I just want to know.
Yes.
Should we label as myasthenia, or do we consider it as a neuromuscular junction manifestation or Sjogren per se?
Yes, sir.
Can Sjogren per se produce neuromuscular junction, and wherein
Yes.
we don't need to give a label of myasthenia gravis?
Yes.
Yes.
So, in your diagnosis, you mentioned myasthenia gravis also.
Yes.
So, do we need to give that label?
Ah.
Or could it be only Sjogren's with sensory neuronopathy, which is also a component of Sjogren's?
Yes, sir. Sjogren's with the neuromuscular involvement also we can. That is correct. That by myasthenia gravis because antibodies are negative. This sense.
So, and the sensory neuronopathy also could be part of Sjogren's, isn't it?
Yes, sir.
So, everything fits in with the single. You see, it's basically like it comes dictum or comes razor. Which do you want to prefer? That's all.
Yes.
So, put everything into one diagnosis, or do you want to have separate diagnosis?
No, sir. Under one diagnosis, I would like to put, sir. Under
So,
Sjogren.
everything falls into Sjogren.
Yes.
Dr. Abhirami, having suspected Sjogren's,
Yes, sir.
have you done any other support investigation? Lick biopsy?
No, sir. She was not.
Have you done the lick biopsy?
No, sir. Lick biopsy, we didn't proceed, sir. She didn't give consent.
Or
sir,
any
for that.
IgG
No, sir,
immunoglobulins
only
complement?
Ideally, ENA could have been done, but she could not afford ENA.
Yes.
That's what she said. Yeah, but can't the neurology department support for an ENA testing?
Sir, they supported, sir, for VGCC and acetylcholine also, sir. Patient was not affordable, sir. We only did.
Okay.
Yes, sir.
But I think, okay.
Sir,
Madam.
can I just have a word? Dr. Banu here.
Banu madam, yeah, please go ahead. Please. Welcome,
Sir,
madam.
I think you can give the diagnosis of Sjogren and also add the other features, because if the patient is going to go somewhere else, they are going to tell the patient you have myasthenia gravis, they had treated you wrongly. So I think it will be better that we add that this is only for the purpose of a summary thing. Sjogren's with myasthenic manifestations and peripheral neuropathy like that. Whether you can call it a Sjogren, I don't know how to word it, Sjogren with myasthenic syndrome, peripheral neuropathy. That way, if you put in the diagnosis, though you don't call it myasthenia gravis.
Okay. Yes, ma'am.
This is just a suggestion. So people who see apart non-neurologists, if the patient goes to a rheumatologist or something, then it may be easier for them to understand what has happened.
Yes.
And did she have any Siddha or Ayurvedic drug intake?
No, ma'am. No, ma'am.
Because recently I've seen two patients, both
Yes.
hypothyroid, under good control.
Yes.
One developed partial ptosis. On evaluation was ACHR positive, and was already seen by an ophthalmologist, where they did an orbital MRI, and they also found all the muscles hypertrophied, orbital muscles hypertrophied, but there was no actual proptosis. So they called thyroid orbitopathy plus myasthenia. But ACHR was very strongly positive. Another patient was, or hypothyroidism, developed multiple cranial nerve palsies.
Yes.
I don't know how to explain. Only common feature I found with both these patients was they had taken some other drugs, not allopathy. So I'm also trying to get them investigated for toxin and also other auto antibodies. They have to come back. But I'm off late. I'm finding this two patients like this, and now you are presenting one more with thyroid and something else. So I just wanted to find out whether they had taken some other medicines from some other system of medicines.
Yes. No, ma'am, she was not taken.
Okay,
Yes.
thank you.
Thank you.
Dr. Abhirami, just what was the potassium level in this patient?
Potassium was normal, sir. 3.2 something. So 3.5, sir.
3.5 is the low limit of normal. Now, did you do ABG? That would sometimes aid in the diagnosis for sure. Very commonly presents with the metabolic acidosis with hypokalemia, isn't it?
Yes.
Vijayan, what was your question? Did you do what?
ABG, acid-based
Oh,
gas.
ABG, right. Okay.
So,
Vijayan sir, that I have one question. We have done a screening for paraneoplastic, that is routine screening. We have not found out anything. Whether we should go for a paraneoplastic profile or wait for malignancy to appear in future follow-up.
I think we should follow this closely, isn't it, sir? We should follow this patient closely, definitely for para. And one more question, madam. Did you do a nodopathy, paranodopathy profile?
No, sir, we didn't. Nodopathy didn't. NF 1.5 we didn't.
That is also coming up in a big way nowadays. That is coming up in a big way nowadays. The neurophasin antibodies can be associated with subacute onset, progressive, some presence with tingling, paresthesias, later on land up with weakness, and sometimes even severe weakness, as in your case. So nodopathy, paranodopathy panel also may be worthwhile doing. They have to be aggressively treated.
Yes.
Vijayan, would it change the diagnosis or would it add some more to the management part?
It might add some more to the management part. So some of these nodopathy, paranodopathy
so,
antibodies, which are
so from the management part, it might be helpful.
We can do DNA profile and lip biopsy that will rule out at least Jogman syndrome.
To answer Dr. Shivakumar, I think it will be better to do the paraneoplastic panel, because if you are going to pick up something, then it may be important to diagnose the cancer earlier, though clinically patient may not have any symptom.
We are waiting for
or something else.
We are waiting
it's
for the
possible.
VGC antibody, madam. And the
Right.
patient has not turned up afterwards. It took about 25 days.
No,
Patient is
that's
from
okay.
outstation.
No, another problem
able to
issue
follow
is
up
that
further.
she cannot afford, madam. Banu
I
madam.
understand, sir. I understand. Since he asked that question, I'm
Yeah,
just
correct.
suggesting.
Absolutely. If it were in Chennai, all the panels would have been done automatically.
Yeah, and some of the hospitals also help in getting it done free, sir. Some of the corporates also. VN sir knows it. At least they were.
I don't know whether it's done free.
Sir, Apollo used to do a lot of
That was
investigation.
earlier days. That was
Earlier,
days.
that's what I said. I don't know now.
But not now.
Okay.
But
Thank you,
anyway,
sir.
Vijayan,
Sir,
anyway, the management is going to be your drug.
sir.
Let's ask them what they did. No, whether it's nodopathy or paranodopathy, the
Yes,
treatment is going to be your favorite drug.
Sir.
Ma, Abhirami, what was the management? Go ahead.
Yes, sir. Management we treated with IV methylprednisolone for 5 days, sir. 1 gram we gave along with the pyridoxine, sir. This fatigability was somewhat improved, sir, but to methylpred she was not responding, sir. At the end of and along with we didn't try any immunomodulators also, sir. We just give methylpred followed by oral steroids, sir. And her stay was for around 20 days, and she was not further willing to stay, sir. And so she went at request discharge, sir. To IV methylpred, she was not responding, sir.
What would you have done? The answer is in the chat box. What would you allow to give?
IVIG we have tried.
No,
sir.
the answer is in the chat box, ma. Just see the chat box. Somebody has posted, Sakti Kumar has posted the question. And I also said it's one of Vijayan's favorite drugs. No.
Cheaper than immunoglobulin.
Vitamin
No,
R.
Sakti Kumar has
Vitamin R.
mentioned about RTX, rituximab.
Vitamin R, madam.
Yes.
Oh.
Shakti Kumar has said RTX.
Yes, sir. Rituximab.
Yeah.
They didn't. Yes, sir.
Right. That should not, that could be, you can arrange for rituximab for her. Less costly than your IVIG.
Yes, sir.
IVIG can be given, sir. Only thing is that it is a recurrent thing. If it is a single time, we can do. If it's a recurrent thing,
another rituximab is cheaper and
yes, sir. Correct.
yes. Any other comments, Vijayan, suggestions?
Excellent case, sir. Well presented.
Yes. Very well worked up and very well presented by
Very
Abhirami.
well worked up and presented excellently.
Thank you.
Would have not done this as a second year PG.
Certainly not. Even I don't know whether you would have done even as a final year PG. Well done, Abhirami.
Thank you.
And your guides, your mentors.
Yes, sir.
Very good.
Thank you.
Shall we move on to the next case, sir?
Yes, Vijayan. Any comments from Justin? He may not be there. Okay, continue.
Good afternoon, sir. Am I audible, sir?
You are audible.
Proceeding the second case for the discussion today, a case of young onset dementia. Our patient is a 41-year-old gentleman. He's coming from Ooty. He studied up to MPhil. He was working as a lecturer in a polytechnic college. He's a right-handed individual and is able to read and write in Tamil and English. His informant was his mother and reliability of information is bad. So he presented to us with chief complaints of forgetfulness for the past 3 years and complaints of difficulty in walking for the past 2 years. So his 24 hours pre-morbid routine was, and he used to get up by 6 a.m. and he usually does his morning routine and then prepares for the college and have breakfast and leaves home by 8 a.m. to college. He used to take lectures there and have lunch along with colleagues, and usually returns home by 5 p.m. from the college and usually spends time with family and chats with friends, and he usually maintains a good social relations and communication with the family. And he used to go for a walk in the evening in a nearby park, and he used to watch TV and also prepare notes for the next day lectures. Then by 8 to 8:30 p.m. he usually has his dinner and then goes to sleep by 9 to 9:30 p.m. So history of presenting illness. Now he was brought by his mother with complaints of forgetfulness for the past 3 years in duration, which was insidious in onset and progressive in nature. He initially had difficulty in teaching at college. He was unable to take lectures as before, and he was unable to plan his work at college. So he lost his job within 5 to 4 months of illness. He often misplaces his key and purse and searches the entire house. And he frequently asks the same question again and again, like to give him the breakfast, even after clarifications given that he already had the food. He often forgets the conversation he recently had. He had difficulty in remembering what, when, and where he had the breakfast, but he is able to recollect his past events, able to remember his marriage date and job joining date. Within 1 year after the onset of symptoms, he had a history of wayfinding difficulties, even outside the house. Once he was lost in bus stand, previously where he used to board the bus for the college. He was searched for the whole day and brought back by relatives. When he was asked for, he said he was trying to go to the college. So after this incident, he was not allowed to go outside even for any getting groceries or the walking. And with the fear of missing him, his mother often locks him inside the house. But he was able to identify the rooms inside the house where he was living. Patient has difficulty in dressing in the form of struggling for buttoning and unbuttoning the shirts and often misaligning the buttons or leaving some undone. So his mother often helps him in buttoning the shirt. and he often wears unclean or old dress repeatedly, which he was never used to do before. So he was always prompted by mother to change to proper clean dress, but he never wears multiple dresses one over the other. And there's no issue of neglecting on one half of the body while applying the soap, and is able to clear the food on both sides of the plate. And he has no history of history of difficulty in handling the money. He was unable to collect the change correctly from the shopkeeper, and sometimes he comes home without collecting the money also. So his mother nowadays started handling the finances. He was able to perform brushing and bathing, but only on prompting. While using chappals, he had no left to right confusions. So past 1.5 years, there is slight change in personality in the form of reduced interest to work. He had decreased interest in family members, and his wife also got separated from him because of these issues. He needs prompting from others to complete the tasks such as eating, brushing his teeth, and bathing. He was no longer interested in watching television or preparing notes for his lectures, and he had a history of bedwetting. Then he started to pass urine in inappropriate places inside the house, like kitchen and living room. When questioned on, he had no guilt. And no history of inability to plan things, and he has history of flopping inappropriately, and there's no history of any irritability, hypersexuality, and there is history of anger outbursts in the recent times. He was able to identify the faces of distant relatives, famous personalities, and able to appreciate the colors. And he has history of difficulty. He has history of difficulty in walking for the past 2 years, which was insidious and progressive in nature. Initially, he had difficulty in inserting his foot into the slippers, and he also unable to grip the slippers tightly while walking. And few months later, he had difficulty in getting up from squatting position, and he has associated with history of stiffness of both the lower limbs. He has no difficulty in raising the arm above the shoulders or mixing the foot. He has no difficulty in turning side to side in bed, raising the neck from the pillow, and no issue of any thinning, twitching, or any variation of movements. He is able to feel the sensation of the clothes he wears, able to feel the hot and cold sensation while bathing, able to feel the hotness of the teacup while holding in hand, no history of any numbness, pins and needle sensation or unsteadiness while closing the eyes, and there's no history of any tight band-like sensation or electric shock-like sensation on bending the neck, and there was no history of any root or neck pain. He was able to appreciate the bladder fullness, able to initiate the urine, but there was history of unconcerned micturition, and there was no dribbling or incomplete evacuation of urine. There was no issue of any excessive sweating or palpitation. He is able to smell well, see well in all directions, able to appreciate colors, no double vision, no drooping of the eyelids, able to feel the sensation of the face normally. There's no deviation of angle of mouth, able to hear well, no tinnitus or vertigo, able to chew, marshal and swallow the food well without any nasal regurgitation, and able to shrug the shoulders. There was no issue of unsteadiness while walking, both in the day or in the dark, and no history of any smearing of food while bringing to mouth. There is no history of any slowness of activity or abnormal movement or any posture. There is no history of any LOC, speech disturbance, or seizures or jerky movements of the limbs. No history of any fluctuating level of sensorium. There was no history of any headache. He sleeps adequately with no limb movements, dream enactment, or talking during the sleep. No stereotypes, no food faddisms, no hallucination or delusions, no compulsive or ritualistic behaviors, and no history of feeling of worthlessness, hopelessness, or helplessness. And there was no history of fever, no history of recent trauma, no history of any joint pain or rash or orogenital ulcers. There was no history of neck or low back pain. So coming to past history, he has no history of any similar kind of illness, and not a known case of diabetic, hypertension, tuberculosis, asthma, epilepsy, and there's no past history of any cerebrovascular or coronary artery disease. And there's no history of any chronic drug intake. Personal history is married, having one child. He was separated now from his wife for the past 1.5 years. He consumes both vegetarian and non-vegetarian diet. He should have a normal sleep and a good appetite. And there's no history of any high-risk sexual behavior or any history of substance abuse. He's not a smoker or an alcoholic. And coming to family history, he's born out of third-degree consanguineous marriage. He had history of similar illness in the elder brother, whose onset of illness was around 35 years of age, and he died within 2 to 3 years after the onset of illness. His maternal uncle also had similar kind of illness 10 years back, and he is also no more. And his father had history of coronary artery disease at the age of 45 years of age, and CVA at around 52 years of age, and he is bedridden. And it's a pedigree chart and showing 2 generations are affected, and one is his maternal uncle, and another one is his elder brother, and both of them passed away. And his father is having coronary artery disease and CV, and is bedridden. And he's married, having children, and he separated from his wife recently. So timeline of events: there is history of memory disturbance involving recent and immediate with impaired executive function for the past 3 years, and a spastic weakness of both the lower limbs for the 2 years, and there is wayfinding difficulties, money handling issues for the past 2 years, and personality change for the past 1.5 years. Summaries. So it's a 41-year-old gentleman who is a college lecturer with no previously known comorbidities, presented with initial onset progressive neurological illness in the form of cognitive impairment involving temporal, bifrontal, parietal, both right and left side, with sparing of the occipital lobe, followed by spastic weakness, and are associated with emotional lability and unconcerned maturation. But there is no involvement of any sensory, cranial, cerebellar, extrapyramidal, autonomic function with the positive family history of neurological illness. Structures involved. Cognitive impairment involving bifrontal, dorsolateral prefrontal cortex involvement with history suggestive of impaired executive function, and a medial prefrontal cortex involvement suggestive of personality change. There is apathy and there is lack of motivation, and orbitofrontal form of anger outbursts and unconcerned maturation. Temporal with immediate and recent memory impairment. Parietal on right side with the wandering behavior, wayfinding difficulties, and there is breathing apraxia. And left side there is difficulty in handling monies with the spastic weakness of both the lower limbs. So account for bilateral pyramidal tract. So account for the ACA territory because of cognitive involvement, and emotional ability pseudobulbar effect is due to frontal lobe involvement.
Ram Prakash.
Yes, sir.
Compliments on an excellent presentation, Ram Prakash.
Thank you.
Very good.
Thank you, sir.
Thank you.
I proceed further, sir.
Excellent presentation, sir. Excellent presentation.
Thank you, sir. Thanks.
Please proceed further. But yeah, only one thing you could have started. It started with memory deficits, isn't it? So first
Yes,
was
sir.
memory. So first was involvement of medial temporal. Then only it spread to other areas.
Yes.
Then it to cingulate medial. Then the next symptom was apathy, isn't it?
Yes, sir. Initially, he had an impaired executive function at this college. He was not able to work as previously. The history is given by his mother. There is no colleague available, and his wife is also separated. So, as far as mother known, he was stopped from
medial temporal, dorsolateral prefrontal, and then orbitofrontal cortex.
Orbitofrontal and
finally parietal also.
Parietal also.
So, excellent, sir. Please proceed.
Okay. So, with the history of case of cognitive impairment in the young with the family history, is look for causes with the genetic and hereditary background. So, first possibly I like to think is leukodystrophies, and leukodystrophy I like to think is first metachromatic leukodystrophy, the late onset type. The points which is not favoring for my diagnosis: patient has no neuropathy. Into 3 years of illness, patient has no development of neuropathy or optic nerve involvement. Another presentation is adrenoleukodystrophy. It's X-linked, and only male people are affected in our pedigree chart. So I also thinking, but only his age group is a little bit older. And second possibility is mitochondrial disorders. I like to think MELAS, but there is points not favoring for my diagnosis. There is no migrainous headache, seizures, and mitochondrial disease usually causes deafness. But in our case, there was no deafness. And third possibility I could think is frontotemporal dementia. And frontotemporal certain cases are reported to have genetic genetic background, and familial cases also reported. And next one is Creutzfeldt-Jakob disease because of cognitive and behavioral changes. But the points not in favor of my differential is there is no myoclonus and there is no extrapyramidal, and CJD usually will have a rapid progressive course. But our patient had 3 years of illness. And next possibility is Huntington's disease. Age and family history are going in it, but there was no extrapyramidal symptoms because most chorea will be the most common initial presentation in the Huntington's disease. So which is not no extrapyramidal symptoms in our patient. HSP I am considering least because dementia occurred well before the development of paraparesis variant. So other possibilities, non-atherosclerotic vascular diseases, CADASIL, and because of strong family history and points not there is no headache, and another possibility is CADASIL. So another possibility Binswanger, because age group in Binswanger's disease is little bit elderly, usually around 50 to 60 years, and is usually non-hereditary. And next possibly Moyamoya disease, but Moyamoya disease usually present with recurrent episodes of TIA, which is not there in our patient. And next possibility considers immune-mediated causes, multiple sclerosis. Our patient has a steady course, so no relapsing and remitting pattern, which is the most common pattern of multiple sclerosis. And another possibility I like to consider because of young patient is autoimmune encephalitis. But autoimmune encephalitis usually would have a rapid progressive course, and there will be fluctuations, seizures, and there will be also associated with movement disorders. So CNS vasculopathies and vasculitis and other causes, SLE, neurosarcoidosis, and Susac syndrome. But our patient had no issue of any joint pain or rash, and Susac syndrome patient usually have hearing loss and vision loss, but our patient doesn't have anything. We also consider possibility of infectious causes and HIV, but there was no fever and other constitutional symptoms. The strong history of family history, but less likely to be a neurocystic cirrhosis or tuberculoma, but I'm considering one of the possible disease. And nutritional causes, vitamin B12 deficiency, but there was no associated neuropathy. Niacin deficiency, there is no diarrhea or skin rashes, and trauma, but chronic STS can also present a similar kind of thing, but family history, and there was no history of trauma going in against for diagnosis. And neoplasms, very slow growing neoplasms like frontal meningioma, glioma, CNS lymphoma can have present like this, but family history, and there was no headache or vomiting in our patients. I'm also considering paraneoplastic causes because of young age, presenting as limbic encephalitis. But less.
Ram Prakash.
Yes, sir.
See, you're given an extensive differential diagnosis.
Yes, sir.
But with the family history,
yes, sir,
what would be your differential diagnosis? Can you narrow it down?
Yes, sir.
Yes.
Please. With the family history, leukodystrophies is possible, sir.
Yes.
Mitochondrial disorders is possible. And familial variant of CJD is possible. Huntington's disease is possible. And CADASIL and CARASIL will be possible.
Okay, one of the differential diagnoses I don't find here is Alzheimer's. Why have you left Alzheimer's off?
Alzheimer's usually present in elderly age group, around 65 years.
Yeah, that's no longer a view held. We have, I mean, there is discussion of several cases of early onset Alzheimer's disease. This could very well be an early onset Alzheimer's, and not alone that, this spastic paraparesis, which he has, also can be a atypical manifestation or a variant of early onset Alzheimer's. So my first diagnosis here would be early onset Alzheimer's with a variant presentation. And these variations are due to genetic manifestations.
Yes, sir.
You proceed. I just wanted to say early onset Alzheimer's, we are not recognizing or discussing early onset Alzheimer's. Early onset Alzheimer's is almost, what should we say, a differential diagnosis, a specific entity, because it occurs earlier age and it has little different manifestations, particularly with memory manifestations starting early.
Yes, sir, as sir told, you should narrow down the diagnosis. Differential
Okay, sir.
diagnosis. Not so many. And as sir told, early onset degenerative early onset, because it's a 3-year course, isn't it? So early onset degenerative dementia should still be considered. Since the memory has been the first manifestation, obviously you should consider early onset Alzheimer's, even before the age of 65. And frontotemporal dementia, yes, even before the age of 65. In fact, young onset degenerative dementias, FTD is more common than Alzheimer's, but still you should consider Alzheimer here, because strongly memory is the striking starting point in this case. So, and then you can narrow it down further rather than listing everything together.
Okay.
Again, Sakti Kumar has said pre-senile early onset Alzheimer's disease. He's put it in the chat box.
Yes.
But one thing is that he is very young, sir. He is in the early 40s. Early onset means around 50 or 50 plus you can think of. But in the early 40s, around 40 years, and rapidly progress, such a rapid progression is an unknown in Alzheimer's disease. Such a rapid progression.
Siva, it is familial,
Yes,
and
sir.
as you know, familial can occur at an earlier age than normal, and it is all related to the gene. So I don't think it's. It is quite possible that this is an EOAD or early onset Alzheimer's disease. I think very much that is likely, and they have a specific gene abnormality,
Also, he
gene
has
mutation.
got a spastic gait, sir. He has a difficulty in walking pyramidal.
Yeah, that's particularly an atypical variant in that particular gene. Spastic paraparesis is known to happen, along with EOAD, that is early onset Alzheimer's disease. The clinical features very well fit in with that, but of course that's genetic. I mean, we'll have to diagnose based on diagnosis to be confirmed only by genetic involvement, or per se. Of course, you can have a MRI showing some. Again, Sakti Kumar has come up, pre-senile 1, and I don't know. Again, that's the gene, pre-senile 1, and Sakti Kumar has again come out with that in the chat box. Sakti, where are you from? Where is Sakti Kumar from? Does anybody know? He always comes up with good differential diagnosis, good points. Sakti Kumar, are you online? Sakti Kumar, where are you from?
தாமரை எங்க மலர்ந்தானே சார்? தாமரை தானே.
யாரு? சக்தி குமாரா?
இல்ல, தாமரை எங்க மலர்ந்தானே சார்? தாமரை தானே.
அது சரி இல்ல, அவரு அடிக்கடி வராரு, நல்லா டிஸ்கஸ் பண்றாரு. ஐ ஜஸ்ட் வாண்ட் டு நோ, எனக்கு சக்தி குமார் எங்க இருந்துன்னு தெரியல, எங்க குவாலிஃபை பண்ண. மேபி ஐ டோன்ட் நாட் நோ. ஆப்வியஸ்லி யூ ஷுட் ஹவ் குவாலிஃபைட் ரீசென்ட்லி, but I don't know from where. He can again put that in the chat box. Sakti Kumar, you can put that in the chat box. Okay, Nama, Vijayan, you can continue the discussions.
Sir, was he an alcoholic? No.
No, sir.
No alcohol.
No showed any substance.
No drug abuse also. Okay. Okay, sir. Please proceed, sir.
So, general physical examination, patient conscious, not owing to time and place, cooperative but comfortable at rest. There was no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or pleural edema. There was alopecia. There was no neurocutaneous markers, no cutaneous markers for any nutritional deficiency. And there was no show in neck swelling, no joint pain, rash, joint swelling, no show thickening of peripheral nose, but there was pseudobulbar effect by the examination. Vitals, pulse rate 88 beats per minute, regular, felt in all 4 limbs. BP 130/90. Mercury in left upper limb sitting posture. On standing, it's 140/90, but there was no postural fall in BP. Respiratory rate is 16 per minute and it's regular. MMC score, I scored 15 out of 30. I lost most of his score in orientation to the time and to place. And then with calculation, is in spite of being a lecturer, is unable to do 100 minus 7 and unable to recall all the 3 words given. And is able to name, repeat, and follow 3-stage command. And is able to read, write, but copying intersecting pentagons is impaired. So score is 15 out of 30, which is severe cognitive impairment. Higher mental functions, this spontaneous speech, fluency is good, no dysprosody, grammar syntax normal, phrase length is good, no paraphasias or circumlocutions or any word finding difficulty, no initiation difficulty, and contents of speech is normal. Comprehension, 1-step, 2-step, and 3-step commands is able to do. Mary's 3-paper test alone is unable to perform. Repetition is able to repeat single words and also sentence of minimum 5 words. Naming, reading, writing was normal. And frontal lobe testing is conscious, and his orientation, year alone is able to say, but unable to say the season, month, and day and date. And the place, country, and state is able to say, but unable to say the floor, city, and hospital, which he was currently he couldn't able to say. Attention, concentration, TAP test, there was error of perseveration noted. Random letter cancellation is impaired. For working memory, we did digit backward test. Is unable to do, we were unable to recall of even the 3 digits. And a test of response inhibition, go-no-go test is unable to perform. And Stroop test, he simply read the name rather than naming the color of the ink. It's impaired. Trial A test, he attempted but marked incorrect sequencing and quit early after marking few numbers. Trial B test, he also attempted but marked incorrect sequence and also unable to complete the sequence. Fluency test is impaired. Word fluency and semantic fluency is impaired. Test of sequencing, graphic sequencing, Luria graphic test is impaired. He made more of perseveratory errors. And manual sequencing also he did perseveratory errors, but repeating the same movement 2 or 3 times in a row without switching. And concentric series completion is unable to do. Abstract thinking is unable to abstract any ideas from the proverbs. He was unable to similarities and difference between cow and goat. Test for intentional motor system is unable to draw a loop and unable to close the eye, able to close the eyes for 20 seconds. And there was no echopraxia. Judgment is impaired, and he had poor insight regarding his illness and hospital admission. Temporal lobe, immediate memory, digit forward test, he is able to do only up to 3 digits. Recent memory is unable to recall 3 words after 5 minutes and unable to recall the story which was told before the test, and unable to say the details of the breakfast. Visual and paired association memory was also impaired. Remote memory alone is able to remember the date of marriage and is also job joining date. Working memory is impaired. Semantic memory able to say the color of the elephant and a number of days in a week. Left parietal lobe testing, tool selection and ordinary tool selection is unable to do. Additional apraxia, when he asked to prepare a letter for a mail or lighting the candle task, he was unable to do. Ideomotor apraxia is able to do only salute, and limb kinetic apraxia is able to oppose the thumb to index, middle, ring finger. And calculation is unable to do forward, backward counting. Is unable to do symbolic transcoding. Is able to read and write arithmetic signs, but written and mental calculation is able to do only for addition and subtraction, that too for 2 digits only. It's unable to align the numbers in the column, and able to identify the fingers in the hand. There is no finger agnosia, and there is no left to right disorientation. Right parietal lobe testing, when he asked to draw a clock, he draw a clock with a poorly formed outline, and there is no idea of numbering or marking the hands, so it's a conceptual defect. Line bisection, there is no heminecket. He is able to exactly bisect center. Construction apraxia, there is construction apraxia, is unable to intersect the pentagon and a Necker's cube. Pressing apraxia, when is given, he is able to insert his hands into slips but unable to button the shirt up and down correctly in a sequence. Topographical disorientation, he is unable to ascertain the location of the immediate objects around the room, and is also unable to recognize the familiar landmarks and unable to identify the draw of map of India, and he also unable to say his route to the ward, and also is unable to recognize his bed in the ward. Hospital lobe testing, vision is around 6/12, and primary visual cortex confrontation is normal, and no cerebral color vision abnormalities. Ventral stream, there is no appreciative or associative visual agnosia, no prospective agnosia, no visual disorientation. On dorsal stream, no optic ataxia. On cookie tip picture alone, is unable to say the whole picture even with cues, but able to say only the individual components in the picture. Cranial nerve examination, olfactory, sense of smell was normal on both sides. Visual acuity 6/12. Field of vision, color vision, and fundus was normal. And 3, 4, and 6 cranial nerve examination, extramucous pool, there was no ptosis or squint. Pupils equal reacting to light. Saccades and pulses was normal. Trigeminal, sensory, ophthalmic maxillary mandibular division was normal. Motor, jaw closing, jaw opening was normal, and jaw jerk was not elicitable. Facial no, frowning of forehead, raising the eyebrow, puffing of cheeks was normal, and there is no deviation of angle of mouth. Vestibular proctor no, Rennie's air conduction is better than bone conduction, no lateralization on Weber's, and observed bone conduction was normal. And glossopharyngeal vagus no, uvula and midline, palatal movements are normal, gag and palatal reflex present. And spinal accessory no, there is shrugging of shoulders and turning head to side was normal on both sides. Hypergloss no, tone was normal, bulk was normal, power normal, tongue movements was normal, there is no deviation on protruding the tongue. Examination of spinomotor system, bulk is no wastings noted, and no asymmetry also noted. Tone, upper and lower limb increased, and there is spasticity to the tone. And power examination, neck muscle flexion extension around 4/5, shoulder flexion, extension, abduction, adduction 4/5, elbow flexion and extension 4/5, wrist flexion and extension 4/5, hand grip 80% on both sides, hip flexion 4/5, knee flexion 4/5, ankle dorsiflexion, plantar flexion 4/5, EHL weak on both sides. Superficial reflexes, corneal conjunctival reflex present, palatal gag reflex present, abdominal reflex absent, plantar extensor on both sides. Deep tendon reflexes, biceps 3+, supinator, triceps, knee and ankle 3+, trapezius pectoralis reflex are elicitable, Hoffman and Waterberg, Hoffman reflex, Waterberg sign of present. There was no clonus, ankle clonus. On frontal release signs, Gebala tap was non-accommodative, bilateral palmomental reflex was present, but snout, rooting and sucking reflex was absent. Gait bilateral spastic, and there was no fasciculations noted. Sensations, touch, pain, temperature, and proprioception sensation normal on both sides. Thrombosis was negative. Cerebellum, there was no titubation, nystagmus, and finger nose incontinence, heel knee test was not. And tandem walking was unable to do. And no involuntary movements or abnormal posture or bradykinesia. There was no resting tachycardia, no abnormal sweating or postural fall in BB. Spine scoliosis noted with convexity towards the left, and cranium normal. There were no signs of meningeal irritation, bilateral carotid subfield. Other system examinations normal. Summary is a 41-year-old gentleman who is an MPhil graduate, no previous program, presented with insidious onset progressive neurological illness in the form of cognitive involvement involving temporal, bifrontal, parietal, sparing the occipital lobe with spastic quadriparesis, with emotional ability and spinal scoliosis and alopecia without any cranial nerve, sensory, extrapyramidal, cerebellar involvement, and with a background of strong family history for neurological illness. The structures involved bifrontal, dorsolateral prefrontal cortex involved, are suggested by impaired test of response inhibition and working memory, mental flexibility, semantic fluency, test of sequencing and abstract thinking. Orbitofrontal involvement by unconcerned maturation and emotional inability, and medial frontal by apathy and lack of motivation. And the left parietal here acalculia, and right parietal constructional, dressing apraxia and topographical disorientation. And temporal impaired immediate digit forward test and recent memory by verbal and impaired story recall. And bipyramidal lesions now above cervical C3 level.
Ramprakash, attention was fairly well preserved, is it?
No, sir. The
How
tablet
was
is
he able to
impaired,
cooperate with you? How was he able to carry out the tests which you have asked for? Even motor tests.
So he is able to do, sir.
That means to that extent, at least his attention is there.
Yes, sir.
Okay. It's not grossly affected.
Not grossly affected.
Yes. He was able to comprehend and carry out your instructions.
Yes, sir.
It's open for discussion. As I said, it's still EOAD with the family history, early onset Alzheimer's. And Saktikumar had already mentioned the genes also, presenilin-1, very likely. He's also mentioned presenilin-2. There is nothing which does not favor that diagnosis, apart, as Siva pointed out, the age group. But if you have the differential diagnosis, if you have anything to show by means of investigation, fine. Other discussions also can take part.
Yeah, what would you consider presenting a presenter? What would you consider? I think, sir, if you had gone, the structures involved, if you are taken according to the temporal sequence, again, as Professor Vian pointed out, memory comes first. Yeah, so when you
hippocampal involvement.
Yeah, that comes first in this patient. So if you go, that is how you should. The structures involved also should go in line with the time of onset of the disorder. Then obviously the first differential diagnosis would still be early onset Alzheimer's disease with spastic paralysis. What is your differential diagnosis, sir, presenting?
Prakash,
Yes, sir, I also thought of early onset Alzheimer's disease, but I also thought of other causes like leukodystrophy is one of the DD I kept, sir. Another working diagnosis is cerebral small non-atherosclerotic vascular diseases also I kept as another DD for working of this patient.
Why did you consider that? You have reasons. Go ahead, tell them.
Yes, sir. Because of strong family histories there.
Exactly.
His father has CV and coronary arteries at very young age, sir. So that made me to think these two was one of the important causes for differential diagnosis.
So maternal side is more affected, not father. Maternal side, there is a history of maternal side affection in this patient.
Father had CAD.
Maternal side.
Yes, sir. His father is also had, but his maternal uncle also had similar kind of illness.
No, father had CAD, isn't it?
Yes, sir. His father had CAD.
Maternal uncle similar means what?
Same history of saving cognitive impairment, sir, with difficulty in walking.
At what age? At what age?
He was died 10 years back, sir. They couldn't say
much. Age of onset. That is important for us. Age of onset in the maternal uncle.
Maternal uncle, he died at the age of 50 years, sir. But
sorry? At what age?
He died at the age of 50 years. They told him he had similar illness 10 years back.
So he also started around the same age, 40 years.
Yes, sir. Yes, sir.
All the more confirming. Yeah.
Yes, sir. His brother also had similar illness at the age of 35, and he also died within 2 years of illness.
Oh, so he started much earlier, 30 years, early 30s.
Yes, yes.
The question is that if it is genetic, if it is inherited from father or mother, it is the issue. Because both sides, their history is positive, whether he inherited from father or mother.
Could be both, sir.
Could be, sir, because there is even consanguinities there. As you go through the pedigree chart, and even father, mother, they had a consanguinities.
So, Siva, enna solreenga neenga? Agayal.
It may be from any side, sir. It may be from both.
Okay. Yeah, continue with your presentation.
Sir, any possibility of autoimmune encephalitis in this patient, sir? Because this man, leaving the family history, leave alone the family history, only the presentation with the dementia at gait impairment, progressive, whether there is any possibility of autoimmune encephalitis, because the autoimmunity is involving every part of the nervous system nowadays. Whether there is a possibility of autoimmune encephalitis, to leave the family history without taking into consideration.
Yeah, if you don't take the family history, certainly in any short duration presentation, cognitive involvement, one of the differential diagnoses will certainly be autoimmune encephalopathy.
Movement disorders, movement
As
disorder
Vijayan,
abnormality.
yeah. Sorry, go ahead, Vijayan.
Movement disorder abnormalities and extrapyramidal syndromes would more favor a autoimmune NMDA. Seizures, movement disorder abnormalities, these would favor a more an autoimmune. Here it's a clear-cut case of starting from the medial temporal lobe, spreading to the temporal parietal association cortices, and also involving the dorsolateral, prefrontal, orbitofrontal, and cingulate. So this case and progression over 3 years, gradually progressing. In this case, still the differential diagnosis would be early onset Alzheimer. HSP plus could also be considered.
Has Ram Prakash presented the investigations or not yet?
Not yet presented.
No.
I'm proceeding with the investigation. Our investigations, complete blood count, hemoglobin is 13 grams per deciliter, total counts is 6,600 cells, MCV is 89, and platelet counts is 251,000, and the peripheral smear showed normostatic normochromic blood picture. Blood urea creatinine was normal, serum uric acid, serum calcium ESR was normal. Liver function test, total bilirubin, direct bilirubin, SGOT, SGPT was normal, and total protein albumin was normal. And lipid profile, total cholesterol is around 200, slightly higher, and triglyceride and HDL was normal. Viral markers, HIV, HbSAg, HCV was negative. Thyroid function test was normal. Serum vitamin B12 levels is 639 picograms per milliliter, normal. Ultrasound abdomen shows a hemangioma of right lobe of liver, 1.1 centimeter, otherwise normal. Chest X-ray, ECG, and echo was with normal. EEG also done for this patient, showed normal record. So CT brain, so non-contact brain CT, showing there is periventricular white matter changes is noted with some atrophy, cerebral atrophy is noted. Other than that, there is no evidence of any acute infarct or hemorrhage. So we proceeded with the MRI brain. This is T1 sagittal cuts showing atrophy of frontal, parietal lobe, and the temporal lobe with retained brainstem and normal cerebellum. And this is diffusion weighted image showing no evidence of any diffusion restriction. And then the next is ADC, which is showing normal signal. And T2 weighted image showing areas of T2 hyperintense signals, mostly around the periventricular region. And FLAIR showing diffuse cerebral atrophy with periventricular hyperintense lesions. MR angiogram was normal. Impression, there's a multifocal chronic lacunar infarct and bilateral capsuloganglionic region and pons, and grade 3 small vessel ischemic changes. There is hyperplasia of corpus callosum with bilateral cerebral atrophy, and MR angiogram was normal.
Go back to angiogram. I think there are pruning noted in the small vessels, distal vessels. The proximal vessels are normal. Sir, what's your comment, sir? Vijay, sir.
Agreed, sir. I agree with you. Definitely, there is a pruning of the M3. Definitely, there is a pruning.
Bilateral.
Yes, sir. Bilaterally, there is definitely. Are you over with the investigations, or are you going to present?
We can discuss now, sir, then we can go on further, sir. We can discuss at this point because these are the routine things done in a medical college hospital. Then we can proceed further.
Again, there's a question in the chat box. Shakti Kumar has asked the question: is there any asymmetrical hippocampal atrophy?
Please show the FLAIR images.
There's no asymmetry.
Please show the FLAIR images, sir. Flare.
You had a flare imaging.
Yes, sir.
That is, the peculiar in this patient is that there is so much of white matter abnormalities, not much of gray matter involvement. But the patient has got a profound dementia. This is one thing which is peculiarly striking us. And we are just wondering why this.
Significant atrophy, Kumar.
Cortex usually, sir, when cortex some atrophy patients are, many patients are usually, they do well with their cognitive function, particularly.
We can't, there's no correlation with the cognitive function and the atrophy. But in this patient, you said significant white matter, there is significant cortical atrophy also. Gray matter involvement also is there.
The obvious next thing to do is a genetic test, isn't it, sir?
Short of doing the genetic test, we don't have that. I don't know whether we'll be able to do the gene, presenilin. Short of that, I don't know whether it's worth going for a biopsy. What would you say regarding a biopsy? Will it yield anything? First place, because yes, the differential seems to be vascular pathology.
Yes, sir.
Am I right, Ram Prakash?
Yes, sir.
Yes, sir. Yes, sir.
So, is there any gene for a vascular pathology? Do we have any genes? Ram Prakash?
Yes, sir.
These are Cadacil and
Cadacil are in DDs. We have.
Yeah, but this MRI, I mean, doesn't show the classical picture of Cadacil. As Vijayan pointed out, there is no anterior temporal finding.
Yes, sir.
Yes, and there is no history of migraines also.
Migraines also, yes.
And yeah, okay, significant cognitive impairment. So, what are you planning? What have you done?
Sir, we have planned for actually genetic analysis in our patients, sir. We did a whole exome sequencing.
Okay.
So, whole exome sequencing told this is the patient's report, sir. So, which is HTRA gene is defective, is homozygous, and is positive for Cadacils.
Oh, very good.
And we proceeded, and we also screened his mother, and he's also having one younger brother, sir. So both of them become a carrier state for this.
Learn, very good. So what are you treating him?
Sir, actually,
how are you treating him, brother?
No specific treatment is there for Cadacil, sir.
Yes.
So we are giving only symptomatic care for him.
But Cadacil, do they progress so rapidly? You might have found some genetic abnormality. Is it unequivocal, this genetic abnormality?
No, sir. It's homozygous.
Sir, yeah. Homozygous, and it's obviously autosomal recessive, and it is present in the mother also, parents also.
There's carrier state also there.
Fantastic workup, sir. Fantastic workup. So it's definitely pathogenic. It's not likely pathogenic in this case anymore.
Again, coming back to the treatment, anything else? Any calcium channel blockers or anything which is help?
We can give only aspirin and ACE inhibitors, sir. That is one thing. We may have some modification of endothelium.
But it is an excellent workup, sir. Excellent workup and excellent workup in also the parents, so that you identified definitely pathogenic, homozygous, autosomal recessive. Well documented, sir. Excellent.
Presentation is good, excellent.
Excellent, sir.
What about what would happen to the vessels in CADASIL? Arterial vessels?
So there will be microangiopathic changes, so there will be arteriopathic, so there will be microangiopathic changes will be there in vessels.
Yeah, what about this pruning? So bilateral pruning, is it a feature of CADASIL?
No, sir, it's not a feature of CADASIL. CADASIL usually involves small vessels, so not large vessels.
The MRI, based on MRI, there's nothing to suggest a CADASIL straight away.
Yes, sir.
And clinically also, well, I don't know whether there are features of a CADASIL.
CARASIL, sir. The CARASIL.
CADASIL, autosomal recessive.
Recessive.
Yeah. Clinical features.
Clinical feature, we had scoliosis in this patient, sir.
Yes.
And somebody had alopecia also.
Ram Prakash, there was a question in the chat box. As soon as you said scoliosis, somebody had asked whether it is correctable by lying down.
Yes,
in supine position, was
yes,
the
sir.
scoliosis, was it correctable? That was a question in the chat box early on itself.
Yes, sir.
Was it correctable?
Yes, sir, it was correctable.
Okay. As Vijayan pointed out, an excellent case, excellent workup, excellent discussion, very good investigations. Both the cases were excellent, a lot of learning for at least old timers like me. I do not know about the youngsters. Very good, very good. Kritika Kannan, she was the one who asked earlier also about the scoliosis. She has again put a question in the chat box. Can you, I didn't have time to read it. Can you answer that? We expect non-correctable scoliosis is what she says. Your response, Ram Prakash?
Sir, usually congenital scoliosis will be correctable on lying down or bending forward, sir. And acquired scoliosis usually will not be correctable.
What did you say? Congenital is correctable and?
Correctable on lying down or bending forward. So acquired scoliosis usually due to any deformities in the spine, so it usually remains uncorrectable. In this patient, it was correctable only.
Kritika Kannan has said, we expect non-correctable. I do not know what is her reason.
Again, it becomes acquired, sir. Maybe when you follow it up with more muscle weakness, asymmetric muscle weakness, it may become uncorrectable also. So that doesn't matter.
As far as we know, anything related to the vertebrae bone, it is non-correctable. Anything related to other structures, correctable.
Yes, sir. That's fine, sir. That doesn't matter.
But what she says is, in CARASIL, it is bony abnormality. It's bony scoliosis in CARASIL. And hence, it should not be correctable.
Not be correctable. Okay. Agreed, sir. But
that's the point. And I think we should congratulate them for having worked up the mother and parents also, and having proved that this is CARASIL. They got
genetically.
So important clues from the parents. Yeah. Very good, complete workup. Shiva,
complete
well
workup, sir.
And
excellent. I think the team.
Our postgraduates are very active, sir.
They should be. They should be happy with such guides.
As good as the teacher, yes, sir.
Yes.
Yeah, the teachers has to become congratulated. Excellent workups.
Vijayan, anything else?
Nothing, sir. Apart from congratulating the presenters and the teachers, nothing more.
And happy to have learned so much.
Yes, sir. Yes, definitely, sir.
உங்களுக்கு இல்ல, எனக்கு.
சார் எனக்கும் தான்.
Any other comments from the participants?
Hello.
Yes.
I am Dr. Paranjoti speaking.
Pardon? You are?
Dr. Paranjoti speaking.
Yes, sir.
Sir.
Paranjoti,
Dr.
sir.
Paranjoti
Welcome.
Pondicherry.
Welcome, sir.
Yes,
Solunga,
sir.
sir.
Sir, regarding treatment, I am notorious or famous for out-of-box thinking.
Yes, sir. We know that.
Yes. My suggestion is amantadine 100 mg TDS. One. Second is ginkgo biloba. Third is citicoline. These three can be tried for this patient, however good it may be. Because telling them no treatment available, but this cocktail will be useful to him, what I feel. You can add alpha-lipoic acid also. These four things will work somewhat in the gray matter of the brain. That's what I feel. Thank you, sir.
Sir, Paranjoti, sir. Sivakumar has started on aspirin and ACE inhibitors.
That is different.
Okay.
That is in a different way of management. See, we can approach things through vascular or blood or with the gray matter. So we have to try all the three. In
So you want
any cases which are totally no treatment is available, we must use whatever available in our hand to try all the three.
So you want amantadine, ginkgo, and citicoline to be added?
Added with alpha-lipoic acid.
Oh, right.
Yes, sir. All is fair in love and neurology.
Yes, sir. But recently, amantadine is in the race. It is now going very well.
For what? Gray matter disease?
Anything degenerative or long-standing hemiplegia or anything. The amantadine will be useful to them.
But the problem is difficult to prove improvement.
Yes. We are not with the FDA controlled or any NINS or any guidelines. We are now going out of box, out of syllabus.
Correct. But how to confirm the improvement? That's what I'm asking.
That we have to observe for a long time.
Definitely indicated in post-traumatic. Definitely indicated in post-traumatic cases. So yes, sir. What sir? Sir has a point.
Vijayan, anyway, post-traumatic cases will improve in the natural course. We are talking of progressive disorders where the natural course will not show improvement. How are you going to confirm? If there is improvement, that in itself will be a confirmation. Certainly, yes.
I am batting for Dr. Paranjoti and amantadine, sir.
Sir, no need to bat for Paranjoti can take care of himself.
The problem is we do not have a good scale to measure the outcome.
Yes.
That is the real problem. Because whatever thing is, patient has to cooperate. So we do not have a good scale like MRI or EEG or any test which is available.
No biomarkers.
Which will show improvement. That is why we have to depend upon the patient's follow-up. It is individualized, not generalized now. Now, future we can do the double blind or RCT, anything you can do that.
Thank you, sir.
Any achievement will be started with a small step.
Yes, sir.
Thank you.
Thank you for participating.
Now why it is called Pondicherry Association of Neuroscience.
Yes, sir.
Sir, now we know why it is called Pondicherry Association of Neuroscientists rather than neurology. The TAN is neurology.
Yes, sir. Yes. We always go beyond neurology.
You're going beyond neurology, sir. That's what Vijayan is saying. It's neuroscience.
Yes. Thank you. Thank you. Thank you, Vijayan.
Keep coming up with your out-of-the-box thinking, Paranjoti, sir.
Yes, yes. I will proceed because, you call me famous or notorious. I don't mind. But I will present
Sir, we love you, sir.
Paranjoti, sir.
We love your...
Paranjoti, sir, you are
yes,
popular.
Sir.
Don't bother whether you are famous or notorious. You are popular.
Popular in several ways. Popular in several ways. Okay, sir. Thank you, sir.
Thank you.
Good case. Interesting discussion.
Yes, sir. And final punch by you.
No.
Siva, anything else, Siva?
Nothing other than thanking you, sir. Thanks for
No, we
choosing us
should thank you
to
for
present.
presenting such lovely cases,
Yeah,
interesting
given
cases,
opportunity,
excellent
sir.
presentation. See, compliments to both the postgraduates. They did a very good job. I don't think they'll have any problems in getting through DM.
Yes, sir. Excellent.
Very well presented. Yeah, history, examination findings, everything was very nicely done. And that only I said credit goes to the teachers.
Yes, sir. Definitely. No, agreed.
So Abhirami and Ram Prakash, congratulations to both of you.
Thank you.
Siva and Thuru, thank you for presenting such very good cases.
Thank you, sir.
And Vijayan for very nice handling of those cases and the chairmanship.
Thank you, sir.
Yes, sir. And of course, to Sun Pharma, thank you for providing all the logistics. And to all the participants, thank you once again. Until we see again. Next month we will have the TANCON. So we'll be meeting there. Wish you all the best. Thank you, sirs.
Thank you, sir.
Thank you.
And Sakti Kumar, well done, Sakti Kumar. யாரும் தெரியல கண்டுபிடிக்கணும். Sun Pharma team, can we leave?
Okay, sir.
Yes, sir. Yes, sir.
Yes, sir.
Okay. Thank you very much. Thank you very much. Ibrahim, sir. Thank you.
Thank you, sir. Thanks, sir.
Thank you so much.
Okay, sir. Bye, sir.
Bye.
Both of them have appreciated those people. Elaborate presentation. Father also career, mother also career. Both they have got a common that is a concern. Father and mother also they are concerned with marriage. Coming from the same tree. Father from veterans. They publish Father and mother also have got a recessive.
Mother and mother, sir. Father bedroom, sir.
Father and mother both are positive.
Mother and elder.
யார் பண்ணீங்க? மதர் பண்ணீங்க.
மதர் younger brother ஒருத்தர் இருக்கார் சார்.
அவர் பண்ணீங்க. Father died.
Father bedroom, sir.
அல்ல அவர் பண்ணிருந்தது. He is also positive.
Serious condition board. Condition on that. Father condition on. Serious.
Well, recessive trait இருக்கலே. May have a recessive trait. He is also coming that pedigree.
Yes.
Same pedigree. Father and mother coming from the single lineage. If pedigree is traceable for a common two. Father பண்ணி பாத்தீங்கன்னா more interesting. இல்ல இவங்க பண்றாங்க ஃப்ரீயா பண்றாங்க பண்ண மாட்டாங்க.
சாம்பிள் இருக்கு சார். சர்ச்
எந்த ஊரு? ஊட்டில சாம்பிள். ஊட்டி மெடிக்கல் காலேஜ்ல ஏதாவது குச்சி ஊட்டி மெடிக்கல் காலேஜ் ஊட்டி எங்கன்னு தெரியல, இடம் தெரியல. போதும், இதுவே போதும். இதே நீங்க ஊட்டில இருந்து இல்ல எங்க தெரியல. ஊட்டினா